Hello friends and a very warm welcome to the NEET-PG 2023 recall session. As it usually happens in any entrance exam, community medicine is roughly around 25 to 30 MCQs and this NEET 2023 was no different. We had approximately 28 to 29 MCQs from community medicine in this exam. And NEET 2023, I would say that it was kind of a balanced question paper. Why? Because there were majority of the question. The main keyword is majority of the questions were super duper easy, where you did not even require more than 15 to 20 seconds to think on those MCQs. They were easy. But yes, I do agree there were some MCQs which are kind of a tricky MCQs. I would not say they were difficult, but they were kind of tricky MCQs where the options were so close that it was difficult for the student to differentiate between the options, and therefore we can label them as difficult. But overall, I would say that this paper was kind of a balanced question. Majority of the questions were, of course, from nutrition, as it always happens. We also had majority questions from communicable disease and national health programs and some related topics from microbiology. Mother-child health, epidemiology, as I always say in the lectures also, that 3 to 4 MCQs are bound to come, and this paper was kind of balanced in this in the terms of chapter distribution. Let's dive into it and let's have a look at the first chapter, MCQs, questions from epidemiology and the health indicators. The first question is, a research was conducted to find the association between aniline dye exposure and bladder cancer. So the theme of the story, the theme of the MCQ is that there were some workers in the industry. You wanted to find, is the aniline dye exposure related to cancer, yes or no? So the two groups were taken, and one was directly involved with dye handling. Another group were office clerks who were not involved with dye handling. So years of occupation were noted from previous record. That is the main beta. The climax of the game is that previous records were taken. That is the main keyword you had to find in the MCQ. What type of study is this performed? So I had already discussed in many times during the lectures also. It is there in video number 8, 16:45 minutes, that what do we mean by retrospective cohort. It is also there in CRPSM, Conceptual Review in PSM, my textbook, 3rd edition, page number 4. We discuss about the retrospective cohort. Whenever a scenario like industrial workers are given in your exam, this is just a hint. Whenever the scenario like industrial workers are given and you have to find the association with cancer, you start your study with the risk factors. It is a cohort study, but you take previous record. Because you take previous records, you go back in time to select the cohort. That is why it is called as retrospective cohort. What is the best answer over here? It is a retrospective cohort. So whenever you want to do a study, today is the date where you do the study today, right? So you go back in time, you take the previous records, you select people who are with the risk factors, and you take people who are without risk factors. And today you find out if these people are having any disease, yes or no. What type of study is this? This is a cohort study. Why do I say a cohort study? Because you're starting your study with what? You start with the risk factors. Because you start with the risk factors, it is called as cohort. And because you go back in time, this is a special type of cohort where you call it as a retrospective cohort. So this is the best answer, retrospective cohort. It is not a prospective cohort because it did not involve any follow-up. It is not a case control because you did not start with people with cancer and no cancer. You took people with risk factor, people with dye industry, and people with office clerks. So it is not intervention and response. That is also a wrong answer. The best answer is retrospective cohort. Question number 2. The best indicator for development in terms of availability and utilization of healthcare of a country. What do you think it is? Is it HDI, that is Human Development Index? Is it infant mortality rate, immunization coverage, and DALI? So a lot of students got confused, sir, whether it is IMR or whether it is HDI. We have already discussed this topic much in detail. It is there in Conceptual Review of PSM. It is also there in Marrow edition 6 video lecture number 69. You find that we have already talked about IMR. IMR is the best indicator for development of a nation in terms of, it is a general overall indicator for health status, important component of the PQLI. So it talks about the effectiveness of the mother-child health services. It is indicator of the health status of the population. So which of the following is the best indicator? It is IMR. But if you sometimes students might get confused that what is HDI. HDI stands for the Human Development Index. So it is kind of a development index for the country. So whenever we talk about development index, we are talking in terms of the standards of living. So it includes standard of living, it includes income, right? Income in terms of the gross national income. It also includes knowledge dimension in terms of the school years. So it includes 2 school years, the expected school years and the mean school years. And third, it also talks about the life expectancy in the area, life expectancy at birth. So there are 3 indicators: life expectancy, knowledge, and income. So whenever we are talking about the Human Development Index, it is more about the development, it is more about the standard of living. But in your MCQ, if they ask you development in terms of availability and utilization of the healthcare, then your answer is not HDI, it is infant mortality rate. That is the best answer. Immunization coverage can also be the good indicator, but it is not about the availability, it is about utilization. DALY is more about life years, about disability life years. It does not account for the availability and the utilization of healthcare. The single best answer over here, of course, it was close. HDI or IMR, both can be correct. But whenever both are given, IMR is the best, single best answer has to be IMR, infant mortality rate. Next is the years of potential life could be attributed to years lost to morbidity, years lost to premature death, years lost to disability, or year lost to poor quality of life. So what do you think is this? This is a direct question from the definition of DALY. So we have already discussed about DALY couple of times in your exam. DALY stands for Disability Adjusted Life Years. So if you talk about the disability adjusted life years, it takes into account 2 things. It takes into account YLD, that is years lived with disability. It also takes into account the years lost to life. That years lost to life, this is what are premature deaths. So please note that DALY is corresponding to 2 things: years lost to life, that is premature death, and that is what your MCQ was, potential life years lost. So this is what is the YLL, years lost to life. So DALY, please note, takes into account the years lost to life. It also takes into account the years lived with disability. These are the disability years. It is one of the good measures. DALY is a very good measure for assessment of burden of disease. Burden of disease is given by DALY. This is a very frequently asked MCQ. Burden of disease is given by DALY. Anyways, in this MCQ, the years of potential life lost is due to years lost to premature death. The answer is, it was talking about the DALY indicator. Years lost to disability is wrong answer. Poor quality of life, that is assessed in the quality adjusted life years. Lost to morbidity and disability are almost the same. So A and C were almost similar. But the best answer over here is option number B is the correct answer in this question. So now moving over to the next topic of next chapter of communicable disease related MCQs from microbiology and national health programs. The first MCQ is a 10-year-old boy with a child with rash and Koplik spots, the most probable diagnosis. Now, do you think you require more time to answer this? Rash and Koplik spots is a pathognomonic feature for measles. Koplik spot is pathognomonic feature for measles. We have already talked about this in video number 28, that what are Koplik spots? These are small whitish spots which are there on the cheek around the first and the second lower molars. And measles pathognomonic feature is Koplik spots. So if you talk about mumps is related to parotid gland swelling. It is related to the parotid gland swelling. Rubella, it is a very self-limiting illness. It is a 3-day illness where the rash will happen and it will just go back automatically 3 to 4 days. The patient will have mild fever and very small rash, which are morbilliform rash from the face. And mumps is parotid gland swelling. Chickenpox, it's a typical rash. It is a vesicular rash. What are vesicular rash? Which are filled with fluid. Fluid-filled vesicular rash, which are pleomorphic. Koplik spot is pathognomonic feature for measles. The pathognomonic sign for measles, it is Koplik spots. What are Koplik spots? These are small spots which are on the first and second lower molars. Most common associated feature in measles, apart from fever and rash, that is diarrhea. Very frequently, child may present with diarrhea also. So, most common complication in measles is otitis media. However, the most common complication leading to death or fatal complication, it is pneumonia. So, these were some of the salient points which are sometimes or very frequently asked in your exam. So, which is the best answer over here for this MCQ? It is measles. Going to the next MCQ, a full-term delivery with baby having signs of prematurity and low birth weight. So till now, it's kind of a general MCQ. This can happen in almost many infections. But now the game is cataract and patent ductus arteriosus. Now tell me again, do you need more time to answer this? This is a typical triad of congenital rubella syndrome. That what is congenital rubella syndrome, beta? Congenital rubella syndrome, classical triad. There are ophthalmic defects, that is cataract. Then there is hearing problem, that is sensory neural hearing loss. And there are cardiac defects, that is patent ductus arteriosus. Rubella, if it happens during pregnancy, it doesn't cause anything, no problem to the child. But if it happens in first trimester, first 3 months, that is 8 to 10 weeks, that is the peak time in early pregnancy, it is disastrous for the child. Rubella happening later on in the pregnancy or during delivery, it doesn't cause anything. But during the early stage, it is disastrous for the child. It may lead to congenital rubella syndrome, cataract, sensory neural hearing loss, and patent ductus arteriosus. So what is the best answer over here? Rubella. Some students might have got confused between the CMV infection. CMV infections that causes low birth weight, prematurity. It's there with everything. Any infection can cause low birth weight, prematurity, but CMV is more associated with liver problem. It may cause neonatal jaundice to a certain higher degree, severe jaundice, hepatosplenomegaly, and the child may also present with retinitis or some other neurological problem. Herpes simplex, again, the child may present with some other immune deficiency diseases, with low birth weight, prematurity, along with in some cases, the child may present with microcephaly also. Similarly, for toxoplasmosis, the child may present with hepatosplenomegaly, low birth weight, but PDA, patent ductus arteriosus, this is a classical triad for rubella, congenital rubella syndrome. Coming over to the next MCQ, a boys' hostel has an outbreak of fever cases with headache followed by development of a pleomorphic rash sparing palms and soles. So this is a classical picture of chickenpox that they had given, and there was an outbreak of chickenpox in the boys' hostel. What is the next best step in management in the suspected cases? So it's not about the other people, it is management of other, like primary prevention of chickenpox to other students. So option number A is isolate for 6 days after giving acyclovir followed by varicella zoster immunoglobulin. Isolate for 12 days after giving acyclovir followed by varicella zoster immunoglobulin. Within 48 hours, only isolate, only give varicella zoster immunoglobulin. So it has been discussed much in detail in the video number 28 and at different timelines and in your Marrow edition 6. But over here in a single screen, I wanted to show you what is there in the Park textbook. So Park textbook talks about page number 160, 161, 26th edition. So I've just taken a screenshot from the book. It is varicella zoster immunoglobulin should be given within 72 hours. There is a very frequently asked MCQ within 72 hours, not 48 hours. But the point is, to whom will you give the varicella zoster immunoglobulin? So it is given to all exposed susceptible individuals who are particularly immunosuppressed. That is the key feature, immunosuppressed, like people with immunodeficiency, susceptible or exposed person who cannot take the vaccine. So varicella zoster immunoglobulin is for low immune status people, females who are pregnant, and in case of high risk susceptible people who cannot take the vaccine. So varicella zoster immunoglobulin is reserved to these kind of children. So generally speaking, whenever there is outbreak, you don't come around as public health measure, you don't give varicella zoster immunoglobulin to everyone. So this varicella zoster immunoglobulin giving to everyone is not correct. It can be given within 72 hours. This can be option, but it is only for people who are at high risk, who have known immunodeficiency, or females who are pregnant. Now in a hostel, in a boys' hostel, if there is some student who is with severe immunodeficiency, they can get the varicella, but it is not given in general to everyone. So this kind of thing is correct. Option A is correct, but it is not given varicella zoster within 72 hours of exposure. In all the suspected cases, we don't give varicella zoster. This is wrong. So it is kind of a correct option in certain situations, but it is not as general rule. I do not agree to this. Option B is purely wrong because varicella zoster is not given in 48 hours. Only isolate for 6 days. This is the best option in public health measures. Whenever there is varicella outbreak, what we do is we have to isolate the children who get varicella. They have to be isolated. Now, because these are children, there is no need to give them acyclovir also. Beta, if you just note that varicella is given to all susceptible, high risk, acyclovir is more like, of course, it has antiviral effect. It is more given in adults where we want to prevent any long-term complications with varicella. So several, textbook from Park, several antiviral compounds provide effective therapy for varicella, which include acyclovir and all these. So they appear to prevent, acyclovir does not appear to prevent post-herpetic neuralgia, but it may be effective in immunosuppressed patients and can halt the progression of zoster in adults. So in children, it is not generally indicated as a public health measure. So acyclovir is also not regularly given. Yes, OCA vaccine, that is the live vaccine. It is a live strain vaccine for chickenpox, OKA. It is for chickenpox vaccine, live vaccine. It can be given to all children who are susceptible. OCA vaccine is given in 2 doses or 3 doses with a minimum gap of 3 months, and this vaccine can be given. It is effective if given within 5 days of known exposure. So in public health measures, yes, we can give OCA vaccine to everyone in case we want to give as a public health measure. But in a country like India, we do not even give the OCA vaccine. So nothing has to be given. The best answer I would like to mark over here is only isolate for 6 days. That is what practically also we do whenever there are reports of cases of outbreak of varicella zoster in the area or chickenpox in the area. So the best answer I would like to mark over here is C. I am not saying that A is wrong. A is also correct, beta, and C is also correct, but C is better answer than A. C is better answer than A. That is why we are going with C. Next is a patient visits to tuberculosis clinic. According to NTEP, what is the next step of patient with sputum negative? Now the patient is sputum negative, but chest x-ray shows signs of TB. Last year, I think 2 years back, they asked the same question where the patient was sputum positive and the chest x-ray was negative. Again, we have had a word on this topic a lot of times in your NTEP modules, but over here I'm showing you NTEP 2020 training modules 1 to 4 for program managers and medical officers. So if you look at this algorithm, beta, we have initially the presumptive TB patient. Now the presumptive TB patient, you are going to do smear examination and chest x-ray. Once you get the smear and the chest x-ray, then there are 4 possibilities which can happen. Either the patient is sputum positive, x-ray positive, sputum positive, x-ray negative, or sputum negative, x-ray positive, sputum negative, x-ray negative. So in all the cases, can you see over here, in all the cases, you are supposed to do CB-NAT. In this MCQ, the question had said that the patient is sputum negative but X-ray positive. So if you look at this topic over here, this point over here, the patient is smear negative but X-ray is suggestive of TB. What are you going to do? Can you see the arrow over here? Can you see the arrow? The arrow goes towards CB-NAT. The best answer over here is to do CB-NAT. It is a super duper clear cut easy MCQ. I would not say it is a difficult MCQ or you had some students got confused that, sir, why not repeat sputum smear? Beta, it was done in 2015-16. It was changed in 2019. The repeat sputum smear was initially it was there in the algorithm. We also used to teach, students used to learn about repeating sputum smear. But nowadays, because CB-NAT is integrated into the system, the best answer over here is CB-NAT. Repeat sputum smear is old answer. It is previous answer. It is a wrong answer. Line probe assay and sputum culture is nowhere in the game. Best answer over here is CB-NAT. It has been discussed in the video number 7, 1939 minutes, and it is there in the revision videos. We have discussed it, of course, in the main ones and in the revision as well. Coming to the next MCQ, a 22-year-old female comes to STI clinic with minimum vaginal discharge. On examination, cervical erosions are seen. Which kit should be given to patient? I'm very proud to say that this is the same MCQ which was discussed in the Marrow integrated video modules with Dr. Sakshi ma'am, and she had taken up this topic much in detail in OBG and PSM integrated session. It is available at various social platforms also, social media platforms also. So this question is similar question, almost 90% similar. A 22-year-old female comes to STI clinic with vaginal discharge. Now the female comes with vaginal discharge. What is the kit you give to vaginal discharge? Everybody thought it is kit number 2 because it is vaginal discharge. But look at the next MCQ, next line in the MCQ. On examination, beta, on examination, the cervical erosions are seen. So if there is evidence of cervical erosions, it moves the game towards the cervicitis. It does not belong now to vaginal discharge. Now this female has syndrome of cervicitis. See, I'm trying to show you, this is a module from the medical officer's RTI STI treatment plan. So this is the training plan for medical officers. You can just see the heading. It is management of vaginal discharge. Now, beta, whenever there is vaginal discharge in females, then you have to see whether it is vaginitis or it is cervicitis. Now, this both can lead to vaginal discharge. If there is discharge in a female, she does not know whether it is from the vagina or from the cervix. You as a doctor has to find out whether it is a vaginal cause or it is cervical cause. So what you do is you do examination. So I'm just zooming into this now. You do examination. This is the zoomed in section of this part, right? So you do examination. Per speculum examination to differentiate between vaginitis and cervicitis. In vaginitis, it is greenish frothy discharge, trichomoniasis. We can have curdy white, which is candidiasis, bacterial vaginosis, and mixed infection. In cervicitis, can you see cervical erosion, cervical ulcers, mucopurulent cervical discharge? Many students started arguing that maybe cervical erosions can be a normal thing, or it can be also seen in other PIDs also, but beta, cervical erosion has to be treated as a cervicitis. You cannot ignore the fact that there is cervical erosions. So these cervical erosions, they should be treated as cervicitis. In vaginitis, there is simple vaginal discharge. So what is the treatment plan? Treatment plan for vaginitis is separate. Treatment plan for cervicitis, it is separate. Cervicitis, we are going to treat it with single tablet of azithro and cefixime, whereas vaginitis is treated with secnidazole, tinidazole, and metoclopramide. But for cervicitis, we give the gray kit, that is the kit number. We give the kit number 1 that is used for cervicitis. In case it is vaginitis, it is kit number 2, that is the green color kit. So if you look at this MCQ, now this is a clear-cut case of cervicitis. So what is the kit you are supposed to give? You are going to give the kit number 1, that is the gray kit. Kit number 1, that is the gray kit. What is the green kit? Green kit is kit number 2. So many students got confused between kit 1 and kit 2, that is the green and the gray. Of course, this is a point of very tricky MCQ, but yes, the best answer, single best answer over here is gray color kit. Moving over to the next MCQ, a young male has a clean wound without any bleeding. The patient received full course of TT vaccination 10 years ago. So patient is cool. He has received TT vaccination, but 10 years ago. What is the best management for the patient? Would you give a single dose of TT vaccine, full course of TT vaccine, immunoglobulin, a full course of vaccine, or a tetanus immunoglobulin only? So what do you think is the best answer? Again, this question has been discussed much in detail in the video number 37. You can just have a look at this. And this is a screenshot from the flashcard for tetanus, which I had posted on social media. So for tetanus, whenever a patient comes to you, you have to categorize the patient, whether it is category A, B, C, and D. What is category A patient? That is the patient who has taken TT vaccine within 5 years. Category B is who has taken more than 5 years but within 10 years. Category C is cool patient who has taken more than 10 years but who has taken the vaccine. And category D is the coolest person who does not know what is happening, never taken TT vaccine, or who does not know about the TT status of that particular person. So you can have category A, B, C, and D. Now in category A, we can have a clean wound or we can have unclean wound. What do we mean by the clean wound? Clean wound is any wound which is aseptic, which is because of some injury, puncture, or some scalpel blade injury, but it should be aseptic, it should be sterile injury, and it should be reported, within 6 hours. If the clean wound is there, but it was reported after 6 hours, it is taken as unclean wound. So clean wound is a wound which is because of sterile things and reported within 6 hours. What is unclean, which is due to contaminated injuries, or which is clean wound but more than 6 hours. So now in category A, you can see on the screen, category A is wound care in both the cases. Category B is you give TT single dose in both the cases. Category C is where the MCQs come. Category C is where the MCQs come, and in a clean wound, we are supposed to give the TT single shot, 1 booster, whereas in unclean wounds, we give the single shot TT plus the tetanus immunoglobulin. That was your best answer over here also. In category D, of course, we are going to give the complete TT schedule. In clean wounds, simple TT schedule, and in unclean wounds, TT full course of tetanus toxoids plus the tetanus toxoid immunoglobulin. Not tetanus toxoid, it is tetanus immunoglobulin. So a young male with clean wound, specifically mentioned clean wound without any bleeding, the patient received full dose 10 years ago. So what is the best thing you're going to do? You are going to give them a single dose of TT vaccine. You are going to give them a single dose of TT vaccine without immunoglobulin. When will you give immunoglobulin? In case of unclean wounds. So this is a direct question, direct answer, option number A. Next question is, a patient is with fever and swelling. The patient is positive for filarial antigen. What is the next step of diagnosis? Now, this question had a lot of different types of recall from the students. Like some said the ultrasound was there or not there. Some said there was Kala-Azar history. Some said this. But if you see from my eyes, probably this question, so I'm not going against the students, but probably this question was pertaining to the lymphatic filariasis. I have discussed this in the videos also, that India is going very strong with lymphatic filariasis, and there is expected MCQs from lymphatic filariasis in time to come. Please note that how do we declare a country as lymphatic filariasis eliminated? If you would have watched the marrow modules, addition modules, we have already discussed that when we are finding about lymphatic filariasis elimination, we do not do the peripheral blood film. We do serological test. These are the rapid antigen test. We do the rapid antigen test. It is done by WHO. It is called as transmission assessment survey. So whenever a patient may have some rapid antigen positivity, it can be there. It is not directly diagnostic. What is diagnostic in Government of India from the National Vector-Borne Disease Control Program point of view? It is thick film formation with peripheral blood film, which is done in the midnight time from 10 p.m. to 2 a.m. This is the most diagnostic modality. Doing a DEC provocation test, it can also be done. Membrane filtration method, it can also be done. From the program point, all three are correct. But the best diagnostic from practical purpose is a thick film, peripheral blood film. Our health workers in the field, they don't know how to do DEC provocation test. They don't have the ultrasound machines. We don't have microbiologists and an ultrasonographers at the lowest level, right? So what we have is the health workers in the rural areas. So health workers are supposed to do the peripheral blood film examination from 10 p.m. to 2 a.m. That is the best diagnostic test. I don't know why students got confused, probably because of see, it happens during the exam. It's actually normal. It's bad of me to say that students did wrong, but it happens that people tend to overthink in the exam. So some said that maybe ultrasound of the testicles to find hydrocele was to be done, or maybe this question had Kala-Azar or lymph node biopsy. See, every option is correct. Option A is you can do this. You can do the DC. It's not wrong. You can do the peripheral. You can do lymph node. Bone marrow biopsy is done in Kala-Azar. That can also be done. But the best practically answerable thing is peripheral blood smear to identify microfilaria. I'll show you a screenshot from the IAPSM book. This is the IAPSM, Indian Association of Preventive and Social Medicine. So if you just look at this, can you read the third line? Identification of microfilaria by the microscopic examination is the most practical diagnostic procedure. I think this arrests the controversy. So probably some of the examiner must have been a part of the lymphatic filariasis program, and they asked about the diagnostic modality. So I personally think that probably PSM examiner was there while making this MCQ, and they asked about the vector-borne program guidelines. How do you classify, how do you diagnose a person with lymphatic filariasis? Can it be diagnosed based on the antigen? Answer is no. We have to, this is the most practical approach to diagnose lymphatic filariasis. We have to do the peripheral blood smear to identify microfilaria from 10 p.m. to 2 a.m. This is the best possible answer. Of course, there was close options. So now let us move to the next chapter about non-communicable disease. If you look at this MCQ, a blood pressure of people were tracked from childhood to adulthood. That's interesting. So blood pressure of the people were tracked from childhood to adulthood. It was observed that those who had lower BP in childhood will have lower BP or low blood pressures in the adulthood also. So children who had higher blood pressures in childhood will have high blood pressures in adulthood. What can this be best described? So it has been a word to word ditto. I have talked about this in the Marrow Edition 6 video number 40, where we have told that low BP should essentially be kept under check, and low BP will lead to a low BP in adulthood. What is this phenomena called? This phenomena is called as tracking of hypertension or tracking of blood pressure. What type of strategy? It is a high-risk strategy. And where do we do it? It is done in the school-going children. So I think it's a very simple direct MCQ. Low BP. See, what happens is, if this is the child, so when the child is born, the BP is kind of low, and as the child will grow in adulthood, the BP will tend to increase. So you have BP over here and you have time over here, right? So what we do as a high-risk strategy, it is kind of a preventive measure. It is a primary prevention. So what we try to do is that children who are currently having low blood pressures, their blood pressures is maintained on a particular track. That is called as tracking of BP. You don't let it go off the track. Tracking of BP does not mean monitoring of BP. Tracking of BP means you maintain a track for the blood pressure. That low blood pressure should be on a lower track, higher will be on a higher track. So you keep people with low blood pressure. When do you have these people with low blood pressure? When they are school-going children. So young children, you make their BP on a track. That is, low blood pressure will lead to lower blood pressure. So this is what is called as tracking of blood pressure. The best answer over here is tracking of blood pressure. It is not at all related to rule of our stepwise approach and primordial approach. What is a stepwise approach? Beta, stepwise approach is an approach used for non-communicable disease. The rule of halves is again used in blood pressures, and primordial approach is a separate MCQ. So this is the best answer, tracking of blood pressure. Coming to the next topic of nutrition. So surprisingly, nutrition had a lot of MCQs pertaining mostly to vitamins, and surprisingly most of them have been discussed in a single video number 83 about the micronutrient deficiencies. So coming to the first MCQ, an alcoholic patient having confusion, visual disturbances and ataxia. So it was an alcoholic patient. This is a classical presentation which is for Wernicke's-Korsakoff psychosis. Wernicke's-Korsakoff psychosis, and it is more predominantly seen in chronic alcoholic patients. It is a neurodegenerative disorder which is associated with memory loss. It is associated with visual disturbances, ataxia, and it is due to vitamin B1 deficiency. Thiamine, it is due to vitamin B1 deficiency. Coming to the next MCQ, an average daily dietary nutrient intake level sufficient to meet the nutrient requirements of 97 to 98% of the healthy individuals in a particular life stage and gender is called as. So it's again from video number 83. See beta, if there are so many people on this planet, right? So you might have your different nutritional requirement. I might have my own nutrition. Even people of your age, people of, let us say all are 25 years of age. So everybody who's 25 years of age, they might have their own nutritional requirement. It could be based on the gender, male or female. It could also be based on your activity. It could also be based on your constitutional system, like whether you are more eating. Some people eat more and nothing happens to them, and some people eat very less and still they are very healthy. So constitutionally people are different, biologically everybody is different. So what level of iron, what level of fat, what level of carbohydrate should be taken so that it is benefiting 97 to 98% of the population? That is what we call as the recommended dietary allowance. That is what this question was. Average nutrient requirement, it is a common sense. Average nutrient requirement will be for 50%. If that number, amount of iron, amount of fat, amount of carbohydrate, calcium is good for 50% of people, that number is called as average nutrient requirement. It is called as estimated average requirement, EAR. So recommended dietary allowance, that is the RDA, that is 97 to 98%. Dietary goal and prudent diet, they are entirely different stories. Prudent diet is a diet which accounts for the dietary goals. And dietary goal, what is dietary goal? That is 50 to 70% of carbohydrate. There should be 10 to 30% of the fat intake, and there should be 10 to 15% of the protein intake. So it was basically a question from exclusion also, even if you did not know the definition. It's a very common sense MCQ. Look at these technical definitions. What is RDA? The average nutrient which is required for 97 to 98%. Adequate intake is what is the adequate, and then you had something called as the estimated average requirement. It is estimated average requirement is for 50% of the population. So best answer over here is recommended dietary allowance. Going to the next MCQ, diarrhea, dementia, dermatitis is seen in the deficiency. Or what do you want? You want me to explain this MCQ? I think there is no exam which has never asked a question on pellagra. This is a typical example of pellagra. Pellagra is because of niacin deficiency. Pellagra is 3Ds or 4Ds, diarrhea, dementia, dermatitis, and death. And this is niacin deficiency or pellagra associated with predominantly maize and jowar eaters, which is because of more of leucine, and it is also because of low of tryptophan. What is the main mechanism? It is low tryptophan, but also more leucine or high leucine is also responsible for pellagra. Going to the next MCQ, raw egg consumption. Again, do you think you want me to explain this MCQ? Everybody knows that raw egg consumption could be because of a protein called as avidin in the egg. So avidin stops or inhibits the biotin production, and avidin inhibits biotin production, and raw egg consumption leads to biotin deficiency. So probably they had given an image in the MCQ where there was alopecia. It leads to alopecia, severe amount of alopecia, and a very severe category of dermatitis. So dermatitis, alopecia, these are related to avidin. Avidin is leading to biotin deficiency. Coming to the next question, 14-month-old child. 14-month-old child presents with scaly pustular lesions in the perioral region and diarrhea. There is also history of poor wound healing, the most probable micronutrient. So this looks like a severe form of dermatitis, or there is a rash there is diarrhea, and it is a 14-month-old child. So it is 1.5-year-old child. There is history of poor wound healing. So it looks like kind of, people might get confused with maize or pellagra also, but there is poor wound healing, and options given are copper, selenium, zinc, or iodine. So many students got confused between copper and zinc. See, poor wound healing, listen to it carefully, poor wound healing and rash. Poor wound healing and rash. It is like common feature of many micronutrient deficiency. It is not that it is related only to zinc, or it is only related to copper, or only related to selenium. It is associated with many micronutrient deficiencies, right? So talking about copper, some students got confused. See, copper, it's a very versatile micronutrient. Like I always say in my classes also, that tryptophan, it is a very versatile micronutrient. Many food products have tryptophan. There are some food products which are anti-tryptophan. That is what is maize. That is why people get pellagra. So copper is a very versatile micronutrient, and it is very difficult to get a copper deficiency. Why would people get copper deficiencies, like low copper levels in their blood? In case of nephrosis, in case of Wilson disease, severe, very severe protein and allergy malnutrition, people might get hypocupremia. So there may be low levels of copper, hypocupremia. There could also be higher levels of copper related to some cancers, Hodgkin disease, lymphomas, leukemias, and there is higher levels of copper in the blood. I'm not talking about Wilson's disease is copper deposition in the tissues, right? It is low copper in the blood, whereas more copper in the tissues. So copper deficiency or excess usually does not happen. It is not a micronutrient which is important from the public health point of view. Because our diet, vegetables, animal meats, most of the diet will have copper element into it. So therefore, copper is never a good answer to answer in your exam. So because copper deficiency does not happen as a public health problem. What happens as a public health problem is about zinc. Zinc is definitely a public health problem. If you talk about the requirement of zinc, zinc is roughly required in 10 to 17 micrograms per day. So this is the level, like 10 micrograms you need in children, around 13 to 15 you need in females, 17 micrograms in males. So that is the amount of zinc you need, and zinc comes mainly from meat products. It comes from milk, and milk products that come from fish. So now the problem is majority of the Indian population, they don't get meat, milk or fish. So people might land up into who are like vegetarian diet, or people who are like very low poverty, or poor people, like 70% of the country is low in terms of the income strata, right? So below poverty line people are living, they don't get access to meat, milk and fish. In these conditions, people might land up into zinc deficiency, which is a very common public health problem. Now, zinc is important for what all things? Zinc is important for immunity building, gene regulation, especially in the blood cells, especially in the neutrophils. It is also important for insulin release from pancreas. And deficiency of zinc can cause low immunity, and therefore a lot of infections can happen in zinc. We can have delayed growth, loss of taste, delayed wound healing, sexual infantilism. Even if the mother gets zinc deficiency, the mother may get zinc deficiency, and because of mother, the child may be having, the female might have miscarriages. There could be intrauterine growth retardation. There could be prematurity also. So many things can happen in case of zinc deficiency, and zinc is definitely a public health problem. So therefore, in your exam beta, it is always good to go with a safer option, that is zinc. Of course, copper can also lead to these kind of presentations, but this is more characteristic for zinc. Talking about selenium, if you just look at the selenium is more like, it's very recently we started working upon selenium, but selenium with vitamin E deficiency, it is related to infections and low immunity and a lot of multiple infections and diarrhea per se. Protein energy malnutrition is associated with selenium, but selenium, again, we don't get a lot of problems with selenium because it is almost many dietary products, food products are sufficient in selenium. Molybdenum can be asked in your exam. It has been associated that there are low levels of molybdenum in case of oral and esophageal cancers, and bony deformities may be formed in case of high consumption of molybdenum, and this can be associated with molybdenum, and these are some of the micronutrients which may be important from your perspective. So coming over back to this MCQ, if you look at the iodine component now, iodine, I think everybody understands that the deficiency of iodine can be leading to hypothyroidism. It can, deficiency can lead to endemic goiter. Deficiency of iodine can also lead to delayed growth. It can lead to any type of cretinism, neurological cretinism or myxedematous cretinism. Neurological cretinism is defined by more neurological features like deaf mutism, severe mental retardation with squint, whereas myxedematous cretinism is more related to the body or the physical cretinism rather than the neurological complaints. Physical cretinism in terms of retarded growth, incomplete maturation of the facial expressions, small and dry hair, eyelashes, eyebrows, delayed sexual maturation, and very less amount of the neurological features. So we can have all these features from iodine deficiency. I think everybody knows about iodine. What is it used for? It is used for production of the thyroid hormones. Which amino acid is also used in thyroid hormone synthesis? It is tyrosine. So tyrosine along with the element iodine is required for thyroid hormone, and deficiency will lead to all these features. So iodine is definitely not the answer over here. So the best answer over here that I would like to mark over here is zinc. I know there were confusing or similar options where it was difficult for the student to choose, but you would have made a wiser guess in case you understand almost everything about these micronutrients. Coming to the next topic, which of the following is the most common cause of night blindness? So even a student from 10th class would know this. Night blindness is associated with vitamin A deficiency. I don't need to explain this. Images seen below is suggestive of which vitamin deficiency. This is bow legs. Bow legs is with vitamin D. We can have rickets or osteomalacia. A typical example of this is rickets, and this is suggestive of vitamin D deficiency. Coming to the next MCQ, in a village, several farmers had a crossed gait in the lower limbs and used a stick for walking support. So what do you think they're talking about? They're talking about neurolathyrism. Due to poor yield of farms, they consume meals with only rice and pulses. Which pulses would you think is the best answer? It is Lathyrus. It is Lathyrus sativus, or also called as Kesari dal. So Kesari dal, it is a dal beta. It is not anything else. It's not cereal. It is not anything else. It is a Kesari dal. It is not a vegetable. It is not a fruit. Kesari dal is dal. Dal is a pulse. So it is Lathyrus sativus. And which vitamin supplementation can prevent the clinical findings? So what is the disease we are talking about? We are talking about neurolathyrism. Neurolathyrism, I think everybody must have attempted this. Please note that neurolathyrism, it is associated with which toxin? It is associated with BOA toxin, beta-oxallyl aminoalanine. It is with the Kesari dal, and it causes neurological defects because it's a neurolathyrism, and there is more damage to the hip and the knee joint. However, which is the first joint? The first joint to be damaged or the first joint to be affected is the hip joint. And then you have what are the preventive measures? The preventive measures are steeping method, parboiling, or vitamin C prophylaxis. Vitamin C prophylaxis, that was asked in this MCQ also. So what is which vitamin can prevent the clinical finding? It is simple. Best answer is vitamin C. Single best answer. Coming to the next MCQ, same question, same topic, same answer. A patient visits to PHC with progressive spastic paraparesis in the lower limb with weakness. The village had successive crop failures and people were facing some financial challenges. See, the Lathyrus sativus, it is a crop which is very easy to produce. So people can do farming without spending too much money on that. And it is a crop which is sold very easily. People buy it very easily and people can make it very easily. So in areas which are facing some drought conditions or financial challenges, this crop has been a lifesaver. But of course, I'm not promoting this crop. This crop has been banned by Government of India. The cultivation of this crop has been banned because it causes neurolathyrism. Which of the following toxin may be implicated? The best answer is BOA, beta-oxallyl aminoalanine. It is not aflatoxin, ergots, or fusarium toxin. So it's the same thing we have already discussed in the video number 84. Coming to the next chapter, that is mother and child health. So there were a good amount of questions from mother-child health and they were confusing options also. Let's have a look at them. A 30-year-old prima gravida presents with complaints of reduced vision at the night. She has been avoiding papaya, mango, and some other fruits throughout her pregnancy because she thinks they could cause abortificans. Now she is presenting with reduced vision. So she's got a problem she can't even see because she didn't eat papaya or the mango. It is the duty of which of the following worker to provide counseling and information to the patient to address these myths? So what do you think you want to answer over here? Is it Anganwadi worker, auxiliary nurse midwife, ASHA worker, or a trained birth attendant? So it could be anyone. So all are correct. I would not say that TBA is not supposed to do this. I would not say that ASHA is not auxiliary nurse midwife or Angana. Everybody is supposed to teach the mother that you have to take papaya and to solve the myths. But the question is, which of the following worker is given the duty of doing it? So I would say that this question is it is absolutely very difficult to mark MCQ because I can't say A is better than B. A, B, C, and D, all options are correct. All are correct. All are correct. Everybody has the job and duty. But if you're going to mark single best answer, look at the screen now. If you look at this video number 41, I have shown you the functions of the ASHA worker. So if you look at the functions of the ASHA worker, the first function or the most important function is always about the home visits. ASHA is also given the main responsibility of taking care of the mother during pregnancy, during her antenatal care. See what happens is, who is working under the NHM, National Health Mission? Look at this. If you understand the whole community medicine chapter as a subject, then you would have answered this, that which is the single best answer. Otherwise, I know that it causes confusion in everybody. See, who's working under National Health Mission? ASHA worker, NHM, auxiliary nurse midwife, NHM or the Ministry of Health and Family Welfare. TBA is again like they are private people, not private. They are not employed by the government, but yes, they are working with the community. So these are community level workers, Okay. Now try to understand that the Anganwadi worker is under which program? Integrated Child Development. What is CD? CD stands for Child Development Scheme. It's a Child Development Services. So how would we have a Child Development Services? This ICDS is more, I would not say only, it is more focused towards a child development. It is more towards eating for the child, supplementary nutrition, non-formal education for the child. It is more about healthy lifestyle in the child. It is more about adolescent growth. It is more about everything about the child. But ASHA worker is more about mother and the child also. Try to understand this game. Auxiliary nurse midwife, she's more about immunization, conducting deliveries. Auxiliary nurse midwife, that is the ANM, that is the MPW females. So they'll be more about family planning in terms of copper T devices insertion, about maintaining records, registers. They are more like nurse. They are more functioning like a nurse. So they are more like technically more advanced compared to ASHA worker. But ASHA is more focused towards having a healthy mother, because healthy mother is going to have a healthy child. But Anganwadi is more towards having a healthy child. Of course, mother also we want to be healthy. So if you get single best answer, I would always promote you to go with the ASHA worker. ASHA workers are given the task of doing what? They are given the task of doing home visits. Every time during my lecture, I always write home visit as the first answer. Because they had been made to do home visits, and they had been, what would they do by doing the home visits? They will go to the female, they will solve any nutritional myths they have, they will promote them to have folic acid tablets in case of early pregnancy, they'll promote them to have iron folic acid tablets in case the pregnancy is after 4 months. So they are going to take care of the mother during ANC. Then they will also take care of the mother and the child in the postnatal care, child care. They will do child care. They will do, you remember, home-based newborn care, HBNC module. It is done by ASHA worker. So everything like ASHA worker has superior functions. Second, if you also remember, ASHA worker is important member of the VHSN. What is VHSN? Village Health Sanitation and Nutrition Committee. She is responsible for the nutrition committee. She is responsible for the nutrition supplements in the village. So the single best answer I would like you to mark is ASHA worker. Of course, I'm not saying A and B are wrong. They are not wrong, but ASHA or the option C is more better to mark. So with that, I would like to close this controversy on this question. But anyways, you have the right to ask me again and again, and I have the privilege of answering you all the time again and again. Coming to the next MCQ again, this question has been quite a talk of the town. A female comes for her first ANC at 8 weeks of gestation. That's pretty early in the pregnancy, and is found to have a hemoglobin of 9%, 9 gram per deciliter. The iron folic acid will be started at. If you would have learnt about PSM from a mother and child health perspective, if you would have watched gynae modules, this has been beautifully discussed, anemia and pregnancy, in 2 separate modules by Dr. Sakshi ma'am in her OBS and gynae lectures. It has been beautifully covered. A female comes for her first ANC at 8 weeks of gestation and is found to have HB of 9 gram %. This female is having anemia in her pregnancy. The iron folic acid has to be common sense, has to be started as soon as possible. What made the controversy? What made the confusion come up? The confusion came up because what we had been seeing in community medicine, look at this guideline for prevention of maternal anemia. Do you understand the word treatment of anemia and prevention of anemia? What I belong to a subject of PSM, preventive social medicine or community medicine, where we are trying to prevent anemia, right? Prevention of anemia. So for prevention of anemia, beta, when do we do hemoglobin estimation? For prevention of anemia, we do hemoglobin estimation. Compulsory hemoglobin estimation by this method has to be done at 14 to 16 weeks, 20 to 24 weeks, 26, 30 weeks, and 30, 34 weeks. 4 to 5 times we do HB estimation in pregnant females. So minimum 4 HB estimations has to be done. This is Government of India Guidelines 2017. The interval should be every 4 weeks, that is every month should be done HB testing. So in case it is less than 4, 4 to 9, 4 to 7, 7 to 9 and more than 10. So you have mild, moderate, severe and very severe classification of anemias. So in these cases, beta, after 14 weeks of gestation, if the female is anemic, we try to put her on iron folic acid tablets. For prevention, it is 1 tablet. For treatment, it is 2 tablets of iron folic acid. In case it is mild to moderate anemia, in severe or very severe anemia, you have to do, in case of severe, very severe, we have to do blood transfusions. In mild, moderate, we do iron folic acid 2 tablets, right? But this is when the female comes after 14 weeks. So this caused the confusion over here. Please note that if the female is presenting early in pregnancy, the female is already anemic, there is no point of delaying that female with the iron folic acid, that I will not give iron folic acid because iron may cause some problem to the female. Nothing is going to happen. Of course, it may have some problem to the female because iron will cause more disturbances in the female. It will cause more nauseatic and more vomiting type of sensation. Already the female is having so much gastric irritations and all these things. But because the female is anemic now, you have to start iron folic acid as soon as possible. You do not delay the treatment. These all 3 are wrong answers. I won't say they are correct. These are all 3 are wrong answers. You have to start iron folic acid as soon as possible. The controversy should be ended over here. Coming to the next MCQ, a 10-year-old child in the school should be given which of the following vaccine? This is a super duper easy MCQ. It has been discussed so many times in different modules. 10-year-old child in a school should be given which of the following vaccine? Rotavirus, it is only given to less than 1 year. So this is a wrong answer. Measles vaccine is only given to less than 5 years. There is also hepatitis B vaccine is only given under the Government of India program as hepatitis B vaccine birth dose. It is given within 24 hours and then it is given with pentavalent vaccine. Pentavalent vaccine, and this pentavalent vaccine in India, Government of India national program, we are giving only to less than 1 year. So birth dose is given only within 24 hours. Why? It prevents the mother to child transmission of the hepatitis B infection. Mother to child transmission, vertical transmission of hepatitis is stopped during this time. So which is the vaccine you are going to give? It is a tetanus, diphtheria, toxoid vaccine. It is given from 10 to 16 years of age. So in fact, we had 2 questions on tetanus. So you should take care about tetanus. And this question has been discussed in the video number 41. Much in detail. I would suggest you to watch the video number 41 in the edition number 6 to know more about immunization, because immunization is a happening topic. Every year you get some questions on immunization. Choice of contraception for a newly-wed couple is condoms, combined OCPs, copper T injections, or copper T intrauterine device, or DMPA injections. What do you think? Newly-wed couple, choice of contraception. So this question has been directly discussed in video number 68. So married female without any children, these are what are the newly-wed couples, newly married couples. So these are married females who do not have any children right now. What is the contraception of choice? It is OCP. IUD is a wrong answer because IUD is something which is interventional. You have to enter into the female. You have to insert a copper T device. Why do you want to insert it? Because of course you want contraception, but there may be side effect of pelvic inflammatory disease, or the female might land up into severe infection, or there could be bleeding also. There could be spotting, more like a female is anemic. You land up into more severe anemia, right? So we don't insert intrauterine devices. DMPA injection can be given, but of course it's not the contraception of choice. Copper T is not there. Condoms has a very high failure rate, so therefore it cannot be given. DMPA also has a side effect. It causes heavy bleeding. So heavy bleeding is also one of the side effect of DMPA, and females who already have heavy menses, heavy periods, for them DMPA would not be very suitable. The best answer over here is combined OC pills. They have the highest efficacy. They have the best efficacy among all the contraceptives in the Government of India contraceptive. So what is the contraception of choice? It is combined OC pills as the best answer. Coming to the last section about miscellaneous or other topics, question number 1 under the other topics. Under the Colombo plan, which of the following is true about cancer treatment? So this question, I don't know why they had asked. This Colombo plan was started in 1951, and this is a historical question they had put about the PET scans. Which of the following is correct? Is it the PET scan for diagnosis of cancer, cobalt therapy, strengthening healthy manpower, help with chemotherapeutic agents? So of course, under Colombo plan, we had cobalt therapy units. We also had strengthening of the manpower for most of the radiotherapy and the telemedicine units. And then there was help with the chemotherapeutic. All A, B, C, D, all are correct. In fact, A to a certain extent, but B, C, D are definitely correct. Now you have to mark which of the following is the best about cancer treatment. So which is the best answer? The best answer over here, this is 1951 Colombo plan. You can see that, I'll just zoom in it for you. You can see that 1964 setting up the radiology department in Jipmer and provision of one cobalt teletherapy under the Colombo plan was the feature of this. This was 1964. This is a historical MCQ, and this I would say is a difficult MCQ for all the students to mark, because you had to study much in detail about how these institutes were started, or how different departments and different institutes were started. But anyways, this is given in your Park textbook also, that the contribution of Canada in supplying cobalt therapy units to medical institutions, it was one of the important feature in the Colombo plan. This is from the Park 27th edition, page number 1018. So the best answer over here you would like to mark is cobalt therapy units. Coming to the next MCQ, during a disease outbreak, the health worker will collect the water sample for bacteriological investigation as. So this is a common sense MCQ. I don't think it was a very hi-fi type of MCQ, but there were close options. Container is kept close to the tap to avoid spillage. Of course, this is not correct, because you don't want to keep the container close to the tap to avoid spillage. You're not talking about conserving water. You are talking about checking for the bacteriological investigation, because the tap may be infected, right? So you don't want to keep the container close to the tap. So turn on the tap for 1 minute, then water is collected. This is correct answer. This is a true answer. Collect water from already leaking pipe. So if the pipe was already leaking, there is a chance of bacteriological contamination from the environment, from the outside also. So why would you collect water from leaking pipe? This is a wrong answer. Collect from a gentle stream of water to avoid splashing. This is also a correct option. So you have to choose which one is the correct option. More correct, B or D. Both are correct, beta. But technically, using technical words, I'm using the technical words. Technically, it is said that you should keep the water flowing for 2 minutes. Of course, you don't keep a stopwatch over there that you see 2 minutes, done 2 minutes, and you check the water. It's not done that way. We usually keep the water flowing for roughly more than 2 minutes. And because you want to catch the midstream. So it is a gentle stream of water to avoid splashing. This is the most appropriate, best answer over here. So whenever in your exam you get some times like 1 minute, it should be done after 1 minute. That is usually not the correct answer. But technically speaking, it is 2 minutes. And this is what is also given in the guidelines about collecting water from for bacteriological investigation. So the best answer is option number D. That is from the gentle stream of water to avoid splashing. However, this question was kind of, I would say that this question will not be repeated ever again, because this is a simple question which has some practical implications. Last question, a factory worker presents with mesothelioma on x-rays. The most probable cause is silicosis, asbestosis, anthracosis, bicyanosis. So this is again a super duper easy MCQ. I think everybody knows that mesotheliomas are associated with Asbestosis. Mesotheliomas are associated with asbestosis. Mesothelioma, please note, we have already discussed this, that asbestosis is a pre-malignant condition. Asbestosis is a pre-malignant condition, which is the most common cancer. It is not mesotheliomas, it does. These are bronchial cancers. These are bronchial cancers. But which is the strongest association? Strongest association cancer is mesothelioma. It is mesothelioma. Strongest association is with mesotheliomas, right? So which is the best answer over here for us to mark? It is a simple direct MCQ. Factory worker with mesotheliomas. What is the most probable answer? It is asbestosis. And with that, thank you so much for watching this whole module on the NEET-PG 2023 recall session.